Pick salvage fixation of failed intertrochanteric fractures. How do I do? So, whenever you are looking at intertrochanteric fractures, bone quality and fracture geometry is important. But what is in surgeon's control, as Dr. Shahane has said, fracture reduction, quality, implant selection, and implant placement is very important. And you can assess actually by scoring how is your reduction by this criteria. This criteria consists of valgus or normal, 160 or 80 in lateral, positive or neutral medial cortical support, or lateral smooth anterior line. So by this you can rate your reduction. But when you have to do revision for failed IT fixation, it is because of acute failure of fixation, unacceptable fracture alignment, and established fracture non-union. Failed fixation, femoral head is preserved by improving mechanical and biological stability by using a varus or valgus deformity correction and using a proper implant and giving a adequate biology by bone grafting and allografts. So when you are considering revision, you should see the residual deformity of the femoral fixation, distorted soft tissue anatomy, scarring, broken implants has to be taken it very carefully because you should not damage the femoral head further by removing those implants, poor bone stocks, and you should also take care of physiological age and life expectancy of the patient. Treatment options are refixation with cephalomedullary nails, bone grafting with cement augmentation, refixation with proximal femoral plate, but the good part is that refixation with angle blade plate has been very rewarding, and salvage arthroplasty. So these are the options. So whenever there is non-union, there is an infection, there is no problem, debride and remove implants. But if there is no infection, if you see your lateral wall is more than 20 millimeter, go for a cephalomedullary nail with the sliding hip screw with the plate, or lateral wall is less, then you can go for 95-degree angle blade plate and nail. But when there is a grossly disturbed anatomy, you can go for the replacement. So coming to the first case where there is an intertrochanteric fracture femur with the extension into subtrochanteric. So this was the fixed with distraction and the no good cortical support. This was treated elsewhere, went into non-union. This was the CT scan when the patient presented to me. This was the CT which confirmed the non-union. This was fixed with condylar blade plate with the anti-rotation plate anteriorly, bone grafted. So open fixation with condylar blade plate with bone grafting and allograft femoral head in elderly failed intertrochanteric fracture femur has given me a good reduction at the end of 1 month, 3 months, and this is healed at the end of 9 months, and you can see the patient is back to the normal activities. So you can save the head. Next case, a lady who has presented to me 2 years after the non-union. One side there is subtroch, other side there is an intertrochanteric fracture with the broken implant. Not walked for 2 years, diabetic, hypertensive, hypothyroid. Now what? Bilateral non-union. So decided to go stepwise. First subtrochanteric fracture, open fixation done with the bone grafting, and waited for the left-sided intertrochanteric non-union. This was the fixation for the right side. This healed completely. So now, after 1.5 years, I decided to go on the intertrochanteric fracture side. So this was fixed with the TFNA2, circlage, anti-rotation anterior plate, bone grafting. So previous bone tract was filled with the bone graft, and then spiral blade was put. Also you can use TFNA with cement augmentation. Third case with the atypical femoral fracture operated outside, subtrochanteric fracture, not IT, but the previous surgeon has used a DHS, resulted into IT plus subtroch now. Patient was followed up subsequently. It has to bound to fail. It failed because subtroch converted to IT, and this failed. Now for implant failure, I revised it with the cement augmented TFNA, circlage, iliac crest bone grafting, allograft, anti-rotation plate anteriorly. So everything has been done, and this is the intra-op pictures of IT non-union, and these are the immediate post-op after doing everything. This is 2 months post-op, this is 4 months, and this is 8 months. Patient started walking normally, was able to do all the activities. So this is not the end of the solution. Patient failed in the bathroom, resulted into this. Now what? Cemented TFNA, circlage is welded, plate is failed, Now one-time solution. Next speaker now will tell us about the one-time solution of hip replacement. So the implant was removed, fixed with the long stem, Wagner stem, and the total hip replacement. Trochanters were fixed with the cerclage. Patient started doing well. Next, this patient had a fall in the household activities, and now what? One-time solution gone. Again came for the fixation because trochanteric abductor mass was completely lifted off. So then I did this fixation of trochanter with the long hook plate, and then patient started developing some bone in the non-union area. Now it is healing well. Another case, intertrochanteric comminuted, treated with recon nail, subtrochanteric extension, went into Z effect, and that's why patient had a non-union, revised with the intertan, bone grafting, and this is healed completely. So another case, basal neck fracture, fixed with DHS, no TAD followed, failed, then revised with valgus osteotomy. This can be basal neck, this can be a intracapsular, but initially it was a basal neck fracture. Then it was treated with iliac crest bone graft. That graft healed and patient came back to normal. Another 69 years old male with intertrochanteric fracture, presented with massage, derotation boot, came back after 1 month no union, 2 months no union, 3 months no union, presented 6 months as a non-union with DVT with the warfarin. Now he wanted to walk. So this was the CT scan of a non-union which was not previously operated, but the surrounding area was swollen with the DVT with the warfarin on. So patient was optimized and fixed with cemented TFNA. Here I have used not the spiral blade but the screw with the cement to compress the fracture and to get the good end result. So this is 8 months follow-up of the same patient of completely healed fracture after 6 months. So what is the algorithm? So if I say ki all non-unions in elderly or middle age should be replaced, no. Failed intertrochanteric fracture, first if the head is destroyed, you can go for arthroplasty. Higher demand, go for total hip. Low demand, you can go for a cemented bipolar if the acetabulum is good. Femoral head condition is good. If there is deformity, you can go for a osteotomy and use 95° or 130° angle blade plate, or even dynamic hip screw with 140 or 145°. If refixation has to be done with the head good, no deformity. If implant, if the head is good superiorly, you can go with the angle blade plate and the intramedullary nail, and if the head is good inferiorly, you can use 95° implant. So before salvage fixation, always rule out infection, remove previous implant with minimal damage, otherwise you can remove the entire head without any use. Correct deformity, varus and valgus, augment biology, and mechanical stability by implant single or dual with cement augmentation and bone grafting or autograft. Thank you.
Thank you, Atul. Next speaker.